3, 2, 1. Good morning. A quorum being present, I call this hearing to order. Without objection, the chair is authorized to declare a recess at any time. We have a number of members participating remotely today. Before we proceed, I would like to go over some items for our members participating remotely. First, if you're experiencing connectivity issues, please make sure you or your staff contact our designated technical support so those issues can be resolved immediately. Members participating remotely must continue to use the video function for the duration of their participation in the hearing unless they experience connectivity issues or other technical problems that render the member unable to fully participate on camera. It is committee and subcommittee policy that members participating remotely will remain muted when not recognized, just like turning your microphone on and off during an in-person hearing. This is out of courtesy to all members on the committee and so that background noise does not interfere with another member who is recognized to speak. When you are recognized, you will need to unmute your microphone and pause for 2 to 3 seconds before speaking to ensure everything you say is captured. If you wish to be recognized, please unmute your microphone and ask to be recognized. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteransaffairs.hearings@mail.house.gov. It will be uploaded to the committee document repository. Please keep in mind that you will need to refresh the repository page as it does not automatically update. Without objection, members will be recognized in order of committee seniority for questioning witnesses today. This will make it easier for me to ensure all members participating have an opportunity to be recognized. Does any member have a question about the conduct of this hearing with members participating remotely? I now recognize myself for an opening statement. I'd like to first start by recognizing our ranking member on the committee, Mr. Bost, and thanking him for his service as chair of this committee and also congratulating him as he will move on in the 117th Congress to be the ranking member of the full committee. So look forward to continuing to serve with you in that capacity. Today, the Subcommittee on Disability Assistance and Memorial Affairs continues its oversight of airborne toxic hazards and burn pit exposure. Today, we hope to learn how can we improve the way that the VA deals with claims for toxic exposure and burn pits? What can the VA do to help standardize this approach for presumptions? And as we know the VA follows multiple studies, what does it do with that research? These important questions must be answered if we want to formulate good policy and efficient procedures to provide our troops a smooth transition to care and benefits as they become veterans. As we discussed in our last hearing, the direct service connection process increases the burden of proof on veterans. What is that result? We learned from June 2007 to July 2020, 12,582 veterans claimed service connection for conditions they believe were related to burn pit exposure. Of those claims, VA only granted 2,828, meaning that 78% of burn pit claims are denied. We need to understand the role of medical examiners and VBA raters. Are there multiple points of failure leading to high denial rates? Or is it time to come up with a presumption for conditions associated with airborne toxic hazards and burn pits? At the last hearing, we heard the VA say that veterans are encouraged to apply for benefits if they have been exposed to burn pits and have conditions associated with that exposure. But when 3 out of 4 claims for burn pit exposure are denied, what signal are we sending to those veterans? VA's approach for tackling the issues of toxic airborne hazards and burn pits is more crucial than ever as we continue to see young service members succumb to illnesses associated with that exposure. We need to know why so many diseases do not have a presumption. It's been 30 years since the establishment of the Agent Orange Act, which provided for a partnership between the National Academies of Science, Engineering, and Medicine and the VA. Since then, this partnership has led to numerous studies, not only of Agent Orange, but also of Gulf War illness and now burn pits. But given this compendium of evidence and research, we need to know if VA has developed best practices for developing new presumptions and future presumptions. Should we rely solely on the private consultation of the VA Secretary and the Director of the Office of Management and Budget? Even with scientific evidence of association, we continue to fight over which conditions to include in the Agent Orange presumptive list for association of exposure. VA previously accepted a minimum standard of limited suggested evidence of association to add conditions to this list, but later and without explanation, changed course and stopped adding diseases that met this or even higher evidentiary thresholds. Despite VA's authority to create presumptions, we in Congress are the only ones making progress on this issue. VA's current model of wait and see is not working. As I've mentioned, VA routinely receives reports from the national academies, but we want to understand exactly what does it do with that research. Moving forward, we need clarity on best practices for creating presumptions. Does a best practice model leverage technology, like the Individual Longitudinal Exposure Record, the ILR, and a separation health assessment, to close evidentiary gaps that lead to better outcomes for these veterans who are seeking service-connected disability? Does available technology like the ILR help our VA researchers narrow the scope of National Academy studies to get better information on the first try? I hope the answers to these questions is yes, and to get a better grasp on what can be done to move the ball faster. I will end with this. 78% is a number that worries me, and it should worry you as well. Brian Graves is a constituent of mine who served in the Air Force for 24 years. During that time, he breathed in fumes from burn pits and aircraft exhaust. Once he got home, the respiratory problems began. Unfortunately, he says the 78% denial rate for burn pit claims has kept him from applying for benefits at the VA for this condition. He feels discouraged from even trying because he thinks his chance of success is so slim. That's the opposite of what veterans should feel about the VA. Veterans should be encouraged to apply at the VA if they need help. I will now turn it over to Ranking Member Bost for his opening comments. Mr. Bost, you're recognized for 5 minutes.
Thank you, Chair Luria, and thank you all for being here today. You know, it's been an incredible honor to lead the Republicans on this subcommittee for the past 4 years, and I'm humbled by the support and trust that my colleagues have placed in me by selecting me to serve as the next ranking member of the full committee. I hope to continue the legacy of the past leaders like Jeff Miller and Phil Rowe, who worked tirelessly to improve the lives of veterans and their families. As a Marine, as a grandfather of a Marine, as a nephew of a Marine, as a father of a Marine, and if I can brag, as of Friday, when he graduates MCRD, as the grandfather of a Marine, I understand the challenges servicemen and women face as they leave the military. And I will use this experience to promote policies that will ensure our veterans receive what they earn. I look forward to working with Chairman Takano to advance critical legislation that will hold the department accountable when needed and maintain the bipartisan manner in which this committee operates. Our veterans deserve no less. On that note, and to turn back to today's hearing, I'm looking forward to discussing how we can improve the delivery of benefits to toxic exposed veterans. First and foremost, we must prevent future service members from being needlessly exposed to harmful substances while in the military. That said, some exposure may be unavoidable, such as when an enemy forces use chemical weapons against our service personnel. Although we cannot undo the harm that these veterans experienced, we owe it to these service members to provide a benefit for disability resulting from these exposures. Unfortunately, in many instances, the records that veterans may need to prove such exposure when applying for compensation are missing, unavailable, or classified. To address this issue, Congress and VA have extended the presumption of exposure to some toxic substances, such as Agent Orange and Gulf War illness. These ease the burden on veterans to show their disability and was caused by their military service. These presumptions have provided access to VA benefits and health care for thousands of veterans. However, not all of the veterans were exposed to harmful substances and have received a presumption. Some exposure allegations require more research, including burn pits and radiation on the, I'm going to say it correctly, in Uwaktok atoll. So everybody here knows what that is. So However, there is no comprehensive processing that the government how research that can inform a presumption is conducted, or how presumptions of exposure can be established by the VA. As a result, the VA has created and denied presumptions based on varying scientific evidence to justify the decision. During the September 23, 2020 DAMA hearing, DAV asked Congress to work with them and the VSO's community to reform and create a presumptive process that is consistent, timely, and accountable for all types of exposures. I agree that the DAV and I am frustrated that we are coming to the end of this Congress without any actionable results on this issue. I was hoping that we would have considerable legislation this Congress which would create a comprehensive presumptive framework for burn pits and other emerging toxic exposures. I know my colleague, Representative Bilirakis, has been working hard with Senator Tillis on their legislative proposals to establish this framework. I intend to work with Chairman Takano, Chair Luria, and to the request that we schedule and I'm going to request that we schedule a legislative hearing early next Congress to consider various toxic exposures related to related legislation. Our veterans have borne the battle in defense of our freedoms. They deserve the assurance that a presumptive system will be in place to compensate them for any disability related to military toxic exposure. Again, I want to thank everyone for being here and taking the time for this morning's hearing, and with that, I yield back.
Thank you, Mr. Bost. I also want to welcome Chairman Takano to the dais today. He'll be joining us virtually. Chairman, would you like to make any opening remarks?
Briefly, Madam Chair, thank you so much for holding this hearing. And Ranking Member Bost, I'm delighted. I know that you know that I've congratulated you privately, but I want to congratulate you publicly. I look forward to working with you on a range of issues, and I want you to know that toxic exposures legislation is a top priority from my standpoint and from the Democratic majority. And I'm delighted that you're speaking out so enthusiastically and forcefully about the need for a comprehensive, fair approach to how we establish standards. And I'm glad to hear you mentioned, in addition to burn pits, exposure to radioactive substances, it's very important that we leave no veteran behind, no matter how small the group is that was affected. We need a fair, consistent way to make sure that all veterans who were exposed to toxic materials during their service are adequately compensated for that and receive appropriate medical care. And you wisely note that we need to avoid exposing them in the first place. We need to work with our colleagues on the Armed Services Committee to up the level of care in terms of how service members are deployed and serve, and we need to be able to monitor them and monitor them, scientifically, and be able to do the epidemiological studies as a follow-up. So let me just say that we did make progress in terms of passing the Blue Water, the Vietnam Blue Water Navy Act, which was decades too late, in my opinion, but it was a significant step forward in terms of Navy veterans that were exposed during the Vietnam War to Agent Orange. And in this NDAA, I'm very pleased that 3 new presumptive conditions are being added. That is an equivalent of $7 billion direct spending through the NDAA. There's still so much more to do, but we did make progress. And I agree with the ranking member that we do need a comprehensive approach. And I can't be more proud of the work that you, Chair Luria, have done in gaining the expertise and bringing all of us together. And I look forward to working with you in the 117th Congress as well on this issue. I yield back.
Thank you, Chairman Takano. I'd like to now thank our distinguished witnesses for joining us today. On our first panel, the Government Accountability Office is represented by Mrs. Elizabeth Kurta, Director of Education, Workforce, and Income Security. She's accompanied today by Ms. Elizabeth Fields, Director of the Defense Capabilities and Management Team. We also have Dr. Sver Vidal, Professor Emeritus of the Department of Environmental and Occupational Health Sciences of the University of Washington. He is here today to speak about his work with the National Academies of Science, Engineering, and Medicine. He testified at our last hearing in September when we discussed airborne hazards in the Southwest Asia Theater of Operations. Welcome back, Dr. Vidal. And finally, we have Beth Murphy, Executive Director of Policy and Procedures of Compensation Services. She's accompanied by Ms. Lorene Carson, Deputy Executive Director, Policy and Procedures of the Compensation Services, and Dr. Patricia Hastings, Chief Consultant with the Post-Deployment Health Services. With that, I'd now like to first recognize Ms. Kurta for 5 minutes to deliver her testimony.
Good morning, Chair Luria, Ranking Member Bost, and members of the subcommittee. Thank you for inviting me to discuss our prior work on presumptive claims for disability benefits. Typically, when a veteran files a disability claim, they must prove that the disability is connected to their military service. However, for some claims, such as those involving Gulf War illness or exposure to the herbicide Agent Orange in Vietnam, VA presumes that certain illnesses are connected to the veteran's service. About 4 out of the 5 million veterans currently receiving disability benefits served during these 2 periods of conflict. Today, I will discuss how VA considers research when adding new presumptive illnesses. I will also discuss particular challenges we identified in 2017 for evaluating presumptive Gulf War illness claims. While Congress has legislated certain presumptive conditions, VA also relies on research by the National Academy of Sciences to identify new presumptions. At the direction of Congress, VA has relied on research reports by the National Academy of Medicine to determine whether illnesses experienced by veterans are associated with service in Southwest Asia and exposure to Agent Orange. As part of VA's process to determine whether to add new presumptive conditions, VA reviews and considers recommendations from the Academy. If the department determines it should add new presumptives, VA develops regulations for those conditions. For example, based on National Academy research, in 2010, VA added 9 infectious diseases to the list of Gulf War presumptive conditions. VA also sponsors Academy research on illnesses that may be related to Agent Orange exposure. In 2018, we reported that VA recognizes 14 presumptive conditions associated with exposure to Agent Orange or other herbicides during military service. The Academy reported that 5 of these conditions had sufficient evidence of association, and 9 had limited or suggestive evidence of association. In 2016, the Academy reported 4 more diseases it categorized as having limited or suggestive evidence of association. And in 2018, one of these was elevated to sufficient evidence along with a newly identified condition. But VA has not yet made the determination to include any of these diseases on its list of presumptive conditions. VA is currently awaiting results from 2 separate studies of Vietnam veterans that VA expects will provide some new evidence to consider. Our work in 2017 also showed that evaluating presumptive Gulf War illness claims can be particularly challenging due to complex decision rules that claims representatives and medical examiners had to follow. In particular, if a veteran had undiagnosed illnesses such as headaches, fatigue, or joint pain, or if the veteran had medically unexplained chronic multi-symptom illness, the process could be more challenging. One challenge we identified was inconsistent requests for disability medical exams. For example, if medical records show that a veteran had symptoms that fall under the undiagnosed illness or chronic multi-symptom illness categories, claims representatives were supposed to request a Gulf War medical general exam. However, we found that claims representatives were not consistently requesting this exam. VA acknowledged the issue at the time and conducted a study intended to ensure future consistency. In addition, VHA medical examiners we interviewed said that conducting Gulf War exams was challenging because of the wide range of symptoms that could qualify as Gulf War illness. We also heard ways in which examiners interpreted VA's guidance for conducting and reporting on the exams inconsistently. These differing interpretations could mean that a veteran's claim was inadvertently denied. In fact, we found at the time that VA denied Gulf War illness claims at a higher rate than other claims. We recommended that VA mandate training on Gulf War illness medical exams for all examiners, which VA implemented. Since the time of our report, VA began allowing contracted medical examiners to conduct Gulf War illness exams. According to VA, contractors are required to take all of the same training as VHA examiners. In 2018, however, we reported that VA did not have a system in place to track and monitor that all contract examiners had completed necessary training. We recommended that VBA implement a process to monitor training, and VBA has not yet fully implemented this recommendation. In summary, research has been key for VA to determine when to add new presumptive illnesses. Many veterans continue to experience medical issues that are not fully understood, making ongoing research important. Our prior work also shows the importance of ensuring that claims representatives and medical examiners have clear information on how to process complex presumptive claims. This concludes my prepared statement, and I and Ms. Field will be happy to address the subcommittee's questions.
Thank you, Ms. Kurta. Dr. Vidal, you are now recognized for 5 minutes.
Thank you. Good morning, Chairman Luria, Ranking Member Bost, Chairman Takano of the full committee, and other members of the committee. Thank you for the opportunity to testify today. My name is Sverre Vidal. I'm Professor Emeritus in the Department of Environmental and Occupational Health Sciences at the University of Washington. As you heard, I'm speaking to you today in my capacity as a member of a committee that was formed by the National Academies of Science, Engineering, and Medicine that produced a report addressing the VA presumptive disability decision-making process. I also served, as you heard, more recently on the Committee on the Respiratory Health Effects of Airborne Hazard Exposures in the Southwest Asia Theater of Military Operations. The National Academies have a long history of advising the federal government on health effects of military service in general, as you've heard, and on the effects of in-theater exposures resulting from military activities in particular. We've also, when requested, offered perspectives on decision-making processes used by the VA in their determination of whether a particular health problem in a veteran may be associated with their military service. The most recent report addressing this issue as it relates to toxic exposures, entitled Improving Presumptive Disability Decision-Making Process for Veterans, was released some time back in 2008. I served on the study committee formed to research and write that report. We were charged with describing the process for how presumptive decisions are made for veterans who have health conditions arising from military service, and then also with proposing a scientific framework for making such presumptive decisions in the future. To address our charge, the study committee conducted a thorough review of relevant research and met with a full range of involved stakeholders, including Congress, the VA, veteran service organizations, and individual veterans as well. We attempted to capture how the VA's presumptive disability determination approach works and completed a series of case studies to identify what we called lessons learned that would be useful in proposing a new approach. This assessment led us to recommend an approach to ensure that presumptive disability decision-making process is based on the best possible scientific evidence, and the approach had the following components. First of all, an open process for nominating exposures and health conditions for review involving all stakeholders in that process. Secondly, a revised process for evaluating scientific information on whether a given exposure causes a health condition in veterans, including first, a revised set of categories to assess the strength of association, the evidence for the association. Specifically, a move away from the use of limited suggestive of an association to a judgment as to whether an exposure was at least as likely as not to cause the health condition. And then secondly, an estimate of the numbers of exposed veterans whose health conditions could be attributed to their military service, including an estimate of the fraction of cases of a health condition that can be attributed to exposure in service. Thirdly, a consistent and transparent presumptive disability determination process by the VA. Fourth, a system for tracking exposures of military personnel and then for monitoring health conditions of all military personnel while in service and after separation. And then finally, some organizational structure to support this process. To support the implementation of our recommendations, we suggested the creation of two panels. First, one was an advisory committee to VA that would assemble, consider, and give priority to exposures and health conditions proposed for possible presumptive evaluation. Nominations for presumptions would come from veterans, other stakeholders, as well as from health tracking, surveillance, and research efforts. The second panel was a science review board, an independent body that would implement the revised process by evaluating the strength of the evidence that links a health condition to a military exposure, and then estimating the fraction of exposed veterans whose health conditions could be attributed to that exposure in the military. This science review board's reports and recommendations would then go to the VA for its consideration, and the VA would then use explicit criteria to render a decision by the VA secretary with regard to whether a presumption would be established. Our report suggested that this framework be considered as a model to guide the evolution of the current approach, and that its implementation would be facilitated by the provision of appropriate resources for the critical participants in the decision-making process. We recognized that action by Congress would be needed to implement all of these components of this proposed approach, but noted that some of the changes could be carried out without legislative action. We concluded that veterans deserve to have an improved system whereby decisions about disability compensation and related benefits are based on the best possible documentation and evidence of first their military exposures, as well as on the best possible information on health conditions that arise from service. Thank you for the opportunity to testify on behalf of the Academy and the committee, and I'd be happy to address questions that you might have. Thank you.
Thank you, Dr. Duvall. Sorry, thank you, Dr. Vidal. Ms. Murphy, you are now recognized for 5 minutes.
Good morning, Chair Luria, Ranking Member Bost, members of the subcommittee, and good morning also to you, Chairman Takano. I am joined today by Lorene Carson, our Deputy Executive Director of Policy and Procedures and Compensation Service in the Veterans Benefits Administration, as well as Dr. Patricia Hastings, Chief Consultant at Post-Deployment Health Services and the Veterans Health Administration. VA is committed to the health and well-being of veterans and is dedicated to continuing to work with our governmental and academic partners to investigate potential health effects associated with garrison and deployment-related exposures. To address veterans' concerns about military environmental exposures, VA created the Post-Deployment Health Services. This office oversees health-related concerns of relevance to veterans and their occupational and environmental exposures. VBA works closely with VHA and our partners at the Department of Defense to identify military exposures and understand health effects from such exposures. In accordance with law, VA provides compensation to veterans for disabilities incurred in or aggravated by military service. To establish service connection for a condition, there must be a current chronic disability, an event, injury, or disease in service, and a link between the disability and the event in service. Direct service connection is the method used to decide most disability compensation claims. Under direct service connection, VA reviews the facts and circumstances of a veteran's case to make a decision on a case-by-case basis. In fiscal year 2019, the overall grant rate among all veterans for disability compensation rating claims was about a 63% grant rate. VA may also consider a claim for disability compensation on a presumptive basis if a regulatory or statutory presumption of service connection has been established. A presumption of service connection relieves the veteran requirement to prove that service incurrence. A presumption of exposure may also be established, which lowers the veteran's requirement to prove an event, such as an exposure occurred in service. While today's discussion may focus largely on the potential for presumptives, a presumption of exposure is not required for VA to grant benefits for veterans whose duties may have exposed them to environmental hazards. For example, since VA is aware that open burn pits were utilized extensively in Southwest Asia Theater of Operations, VA will generally concede exposure to burn pits if a veteran served in Southwest Asia. Although no presumption of service connection has been created for Gulf War veterans for conditions related to burn pits, the grant rate for common respiratory conditions for deployed Gulf War veterans is 64%. Again, the grant rate for common respiratory conditions for deployed Gulf War veterans is 64%, and it's 58% among their non-deployed counterparts. When establishing a presumption, the Secretary of VA has rulemaking authority under the law to provide a presumption of service connection for diseases associated with toxic exposure. This includes establishment of presumptions of service connection or exposure under specified circumstances, provided there is a rational basis for the presumption. For example, in 2017, the Secretary used his authority to establish presumptive service connection for several diseases based on exposure to toxins at Camp Lejeune. If VA identifies scientific and medical information regarding a particular exposure and a potential health outcome from such exposure, then consistent with guidance in VA Directive 0215, a technical working group is established to review and make recommendations to the Secretary. Such working group is comprised of experts in healthcare, epidemiology, research, as well as VA disability benefits. If the Secretary, in collaboration with other federal partners, establishes a presumption, then VA would implement the decision. This includes providing policy and procedural guidance and training to claims processors, clinicians, compensation and pension examiners, and other employees. VA would conduct outreach to veterans and stakeholders. Also, VA would initiate rulemaking to establish the presumption and regulation, which would be subject to administrative, legal, and public review. The rulemaking process, on average, takes about 18 to 24 months. In conclusion, VA is committed to ensuring that all veterans' claims are processed and decided in a fair and equitable manner. This includes establishment of presumptions if there is sufficient scientific and medical evidence demonstrated. VA's continued partnership with DoD to identify and understand military exposures is critical, as well as VA's efforts to study health outcomes and claims activities for veterans who were potentially exposed to environmental hazards. Thank you, Madam Chair, for your ongoing support. This concludes my testimony, and we welcome your questions. Thank you.
Thank you, Ms. Murphy. I will now recognize myself for 5 minutes for questions, and I would like to start with Ms. Kurda. The Government Accountability Office, GAO, has conducted oversight on the way that claims for Gulf War illness and burn pit exposure are handled. And I understand that in the case of Gulf War illness, some issues with training, which you mentioned, might explain the high rate of denial. I know this was addressed previously through training on the examiner side, but as you mentioned, the recent shift to CMP examiners being contract examiners, I believe could have some impact on the consistency of that training, and as you noted as well, there's not a system for tracking or documenting that training amongst contract examiners. So one thing I would like for you to further comment on the impact of that, as well as do you see issues with the training for developers and raters, the consistency of the training they receive or adequacy of that training? And did you witness any disparities amongst regional offices within the VA related to that training?
Certainly. With regard to the contracted medical examiners now performing the Gulf War medical exams, we are concerned about the risk that is posed when the agency cannot sort of fully monitor that all the the medical examiners have received required Gulf War medical exam training. Without such a system, VBA risks using contracted examiners who are unaware of the agency's process for conducting Gulf War general medical exams and reporting the results. Further, medical examiners may not be able to reliably and consistently carry out their responsibilities with regard to conducting and reporting on Gulf War exams and provide adequate information for decision-making to VA's claims rating staff. This could also lead to delays for veterans as a result of poor quality exams that need to be redone or insufficient exam reports that need to be corrected. It can also result in inadvertent denials. With regard to training for raters, in our past work in 2017, we did see inconsistencies in how these trainers, how these raters decided whether to order a medical exam. It's a very complex set of sort of decision trees depending on the circumstance of the Gulf War illness that the veteran is claiming, and they were not always consistently making the right call. VA has done some work subsequent to that report to better ensure consistency, but we have not looked at that more recently to be able to say how things are today. And then with respect to disparities across regional offices, we did find at the time in 2017, there were disparities in approval rates for Gulf War illnesses across different offices, which also just suggested to us that work on consistency was necessary at the time.
Well, thank you for that feedback. And I know that the research that you mentioned in your response was centered around Gulf War illness. Have you collected any data specifically related to burn pits and similar trends or patterns affecting the high disapproval rate that we're seeing currently reported at 78% for those who specifically mentioned in their claims exposure to burn pits?
We have not looked at that issue of burn pit approvals or denials, and we have not been asked to look at that issue. So we don't have that information, but I'm sure VA has more information on that.
Thank you. And I guess in the little bit of time I have remaining, I turn to Ms. Murphy just to address that same topic.
Yes, thank you. In 2017, we shared your concerns of the training, the exams, all of this, and we've done quite a bit of work across all of those areas since then. We provided training to all of our raters and our claims processors. We've recently updated that training just in the last fiscal year. Going forward, we do have more C&P exams being conducted by contracted examiners, and I'm happy to say that they are specifically required to do general medical examination Gulf War training to be certified to do exams in 5 different areas, and this is the same VHA training that was developed. We do have a system in place, and we're tracking that. Twice a year, we have to validate that they have completed their training. They're required to repeat the training every 3 years, or if they haven't done an exam in the last year, to repeat the training at that time. So we have done training of our employees, training and validation of training for our examiners, and we continue to also look at this on our site visits at regional offices.
Thank you. Well, my time has expired, so I'll now recognize Mr. Bost for 5 minutes for questions.
Thank you, Madam Chair. Dr. Vidal, there have been, numerous studies on the negative health impacts of prolonged exposure to open-air waste burning. For that reason, I was surprised that the National Academies in September 2020 report on the burn pits only found a limited or a suggestive evidence of an association between the respiratory symptoms and the in-theater burn pits exposures. Can you explain why the NAS could not conclude additional disability were linked to the burn pit exposures? For example, was the approach of the NAS used for the September 2020 burn pit report different from prior toxic exposure studies?
Thank you. No, so I don't think the approach was markedly different from what had been taken before. We did a very comprehensive review at that time. And the reasons for that designation with respect to burn pits and respiratory hazards in the Southwest Theater were largely because of the quality of the studies. So we had limited our look at in-theater exposures, and the quality of the studies did not allow us to make any more firm characterization of the evidence than what we did. There were, for example, with burn pits in particular, there were many more studies that did not show an association than for just deployment in general. So as a result of that, we ended up really showing that, or concluding that the only health outcome that we felt comfortable even moving up to limited and suggestive was the respiratory symptoms, even though there were some weaknesses in that scientific evidence as well. Nevertheless, there was much more consistency with respect to that health outcome. With respect to other health outcome measures, I think as we reported the last time when the focus was on that specific report, the health evidence just had so many weaknesses to it that we couldn't assign a category of limited suggestive to them. So what was left with, at least from the respiratory point of view, not talking about any other health outcomes, at least, is that respiratory symptoms would have met the limited and suggestive characterization.
Okay, I'm going to follow up with this. And so how can the VA modify its current research on the health effects of burn pits exposure to incorporate NAS's recommendations from its recent study on airborne hazards?
Yeah, so now I probably am speaking not without having been vetted by the committee, but my own sort of opinion. I mean, what we have is this designation of limited and suggestive from that NAS report. However, as you heard from what I had relayed relative to the 2008 recommendation, is that we try to drop that designation or that characterization of the evidence and move to something that's a little bit more, I think, inclusive of all of the evidence that's out there. That is at least as likely as not causation. Now, there is a link. There definitely is correspondence between limited, suggestive, and whatever we had proposed in 2008. But it's not complete correspondence. And so in the short term, one might consider using limited and suggestive for those respiratory outcomes, and specifically the respiratory symptoms, as an entrance point or as a starting point to consider presumptions. But as you're probably aware, respiratory symptoms by themselves is going to be problematic, and so one would like to have some confirmatory or supportive evidence with respect to symptoms. For example, that they occurred either during or after deployment, or at least substantially worsened. Asking for some estimate of exposure, although that could be a tough ask and wouldn't be necessarily required, at least to start with. And then finally, some objective measure that would confirm the report of symptoms. And what those objective measures could be, I think, would be subject to some deliberation. But that would be at least a starting point to incorporate the findings of the most recent NAS report, and as it links to the recommendations for the presumptive disability decision-making process report in 2008. Now, that report is now long in the tooth, as you know, from 2008, and there's probably a lot that's gone on, since that time. But even testimony in 2019 by the chair of that committee, John Samet, as well as testimony by David Butler of the National Academies, essentially left the findings of that report unchanged.
Thanks, Dr. Vidal, and my time has expired, but I wanted to just say this. I hope that, Dr. Hastings, at some time you can say whether or not it is your intention to implement these recommendations. So with that, I'll yield back. So,
Thank you, Mr. Boss. I'd now like to recognize Chairman Takano for 5 minutes.
Thank you, Chairwoman Luria, Chair Luria. My first question is for Ms. Murphy or Mr. Carson or Dr. Hastings. As you know, that in fiscal year 2021, well, as you know, the fiscal year 2021, the NDAA provided as an act into law will add hyperthyroidism, bladder cancer, and Parkinsonism as presumptive diseases associated with exposure to Agent Orange and other herbicides. However, there are other diseases that have been identified on the Academy's lists, including hypertension, for which the Academy determined have sufficient evidence of association with herbicide exposure. My question is, you've mentioned in your testimony that presumptions are created using a rational basis. Does a NAS finding of limited or suggestive evidence of association meet the rational basis test? If every one of you would just sort of weigh in on that very briefly.
Thank you, Chairman Takano. We are aware of the NDAA conditions that you mentioned. Our legislative department has been tracking that status, and should they be implemented, VBA is poised to implement that accordingly. I am not the scientist in the room, so I would ask Dr. Hastings to comment on that, please.
Chair Takano, we looked at hypertension specifically, and it was put in the sufficient evidence category. And actually, the study that moved it into that category was done by my office, Post-Deployment Health Services. However, when you look at the general United States population of the same age group, about 80% also have hypertension. So we are looking at it further with the VE Heroes and the Vietnam mortality study. It was not felt, even though it was in the sufficient category, that with the rest of the U.S. population being at such a high level, that that was indicative that it was caused by Agent Orange.
Thank you. Ms. Murphy, your statement did, I mean, you did lay out rational basis as sort of a standard. I'm trying to get a sense from you how that's defined, how we define it. I mean, do we define that as, the idea that limited or suggestive evidence of association, does that meet the rational basis test?
Chairman Takano, I know that there are the technical working groups and the strategic working groups that make the recommendations to the Secretary, and the Secretary, working with other federal entities, federal partners, has to weigh the evidence. They look at the studies from the medical community, from the scientific community. As Dr. Hastings mentioned, that's not in a vacuum. They have to look across other causations, and if they're seeing that predominance for hypertension, for example, in the general population, that has to be taken into consideration as well. My science background is limited, so I think that's my statement, that we have to take it in totality, weigh all the evidence, and determine if there is sufficient medical evidence, scientific evidence.
I'm just trying to pin down what rational you used it in your statement about rational basis being a standard. Presumptions are created using a rational basis standard, and so what is that standard? I'm trying to get to the bottom of that.
Dr. Hastings, can you add to that?
Absolutely. In most I'm so sorry, I keep forgetting to hit the on button. The rational basis in most cases is the National Academy of Science, Engineering, and Medicine, where they've reached sufficient level, and we also use the limited or suggestive. However, when the technical working group and the strategic working group and the task force, 3 different groups, look at it before it goes to the secretary, we want to ensure that we have the best science available, that there is no other information out there that we need to consider. And in this case, there are some other cases to consider. With the presumption, in most cases, it is indeed based on what the National Academy has done, but we take everything in totality and look at other items also that may have been missed by the Academy.
So it's not uniformly based on a suggestive standard. It could vary. It doesn't. It's not. It could be that, but it's not always. Is that what you're telling me?
In most cases it is, but for example, in the specific case of hypertension, because it is very common in the general U.S. population, we are looking at that further. I will say that spina bifida was regarded as being in the limited or suggestive category at one time for Agent Orange. It has been moved out of that category to the no evidence of an association, and so doing things too early sometimes puts them in the wrong category. So we are looking at hypertension specifically a bit further.
Chair Lurie, I can't see a clock, but I have a sense that I'm probably run out of time. I'll try to submit the rest of my questions for the record, but I yield back.
Well, thank you, Chairman Takano. I think we will have the opportunity for additional questions if you're able to stay with us. So I'd now like to recognize Mr. Bilirakis for 5 minutes.
Thank you. Thank you, Madam Chair. I appreciate it very much. Before I begin my questions, I just want to associate myself with the ranking member, the comments of the ranking member, my friend, Mr. Boss, sentiment that we need to move forward with legislation that establishes a process for all toxic exposure claims, particularly for burn pits. This has been a priority of mine. There are multiple legislative ideas out there, including bills that I've introduced, and I know that Dr. Ruiz, who's not on this particular committee, but was on Veterans Affairs and cares very much about our veterans. He's introduced bills, and I've co-sponsored most of those bills as well with regard to burn pits. So we need to move the ball forward on this issue. And frankly, we've been talking far too long. We need to take action. Time is of the essence. Now, I really appreciate what the chairman has done, particularly the provisions in the NDAA with regard to burn pits. But again, it's not just limited to burn pits. This is an issue we've got to act on as soon as possible. We need to get this done, and I urge my fellow members as we look to the next Congress, this be one of our top priorities. Our service members have waited too long, particularly for the health care. So again, I have a couple questions. The first question is for Ms. Murphy. Why has the VA historically made changes to the rating schedule rather than Congress?
As far as the VA schedule for rating disabilities, or the VASRD as we call it, it is in regulation, and it is the guidebook that in the regulation part 4 of 38 Code of Federal Regulations that we publish for our raters and our decision makers. They use that as a guide for when they determine service connection and at what levels of disability they assign for service-connected conditions. So it's in regulation. It's something that my office manages, and we have a designated team as of last year that is doing that program management of the rating schedule. And I'm happy to say that for the first time in over 70 years, we will soon, by 2023, have the first holistic update of the rating schedule since 1945. So we're very happy with that. And then we have a program plan to continue a cyclical review of that on an ongoing basis rather than waiting for another 75 years.
We appreciate that. Likewise, I also believe that it should not be Congress's role to determine specifically which conditions are eligible for future presumptions of exposure, such as burn pits. That is something that is much better equipped, in my opinion, for actual scientists and medical experts rather than the political body. But you know, time is of the essence. My bill, the TEAM Act, which is HR 8506, would prescribe specific, and Representative Boss, who will be the ranking member Boss of the full committee, and I congratulate him. He mentioned this particular bill that I'm doing with Senator Tillis. But again, the TEAM Act, HR 8506, would prescribe specific timelines, and the required evidentiary standard VA must use when creating presumptions. But VA would be responsible for reviewing the science and determining which conditions warrant a presumption. Can you explain whether VA, again, this is for Ms. Murphy, can you explain whether VA would have any challenges implementing such a process, which requires VA to determine whether to extend a presumption following NAS reports on associated health effects of certain toxic exposures? Again, the toxic exposure issues. Can you please elaborate on that, Ms. Murphy? I would appreciate it.
Yes, sir. I want to say that VA, particularly VBA, we don't resist establishment of presumptives when they are done through law, through statute, or there's scientific basis and for the Secretary to pass a regulation. We stand ready to implement, just like we did recently with the Blue Water Navy Act, passed at the end of June of 2019 and implemented January 1st, 2020. I believe, and Patricia, Dr. Hastings can assist here, it sounds like we could follow the same process, similar process that we have as far as establishing presumptives, doing that homework together, VHA, VBA, the scientific community, Department of Defense. Patricia, can you add to that?
Yeah, I think that would be very helpful. Thank you.
Thank you, sir.
Absolutely. This is a team effort. We do want to utilize the efforts of the National Academy, but in cases where there is other information out there, whether it's mechanical issues, animal studies, global health studies, we do want to add those. We have EILER that will be useful in the future. I will note that when presumptions get to the Secretary, there are many times that we have to coordinate with our other federal partners, and that may slow things down.
Okay, well, thank you. I know my time has expired. I appreciate it, Madam Chair. I yield back.
Thank you, Mr. Bilirakis. I now recognize Mr. Allred for 5 minutes.
Well, thank you, Madam Chair, and thank you all for making this work remotely. I am very glad that we're shining a light on burn pits and toxic exposure for our veterans faced while they're on active duty and while deployed. Last year, the chairman of the committee and I and a few others, members of the committee, went to Kuwait and Afghanistan, and I was struck by how poor the air quality was in Kabul in particular. As you might know, Kabul sits in sort of a bowl-like valley surrounded by mountains. The residents of the city burn pretty much everything, both for energy and for light, leaving the air quality similar to breathing through an exhaust pipe. In fact, I just looked up the air quality index in Kabul right now, and it's at 193. Which the American Lung Association says is unhealthy, and it's right on the border of becoming extremely unhealthy. And I think as the winter deepens and as the evenings stretch, the air quality often is in that range. And Dr. Vidal, I was reading your testimony, and I was wondering if you could just say whether or not we're tracking this kind of exposure properly, and how, for example, a respiratory claim would be viewed by the VA from, say, some of the Marines that we met who are serving at our embassy in Kabul, and whether your recommendations would capture service-related impacts like this.
Thank you for, enlarging the focus of what exposures are concerned in those deployed. Certainly burn pits are, but there are multiple other exposures, and certainly air pollution, regional and local air pollution is another one. Most of the research that's been done has not attempted to look at specific types of exposure like that. And what I mean by that is that most of the research has been deployment versus non-deployment, and which is admittedly a very crude measure of assessing exposure. There have been some studies that have tried to incorporate the ambient air pollution as well, but those are few and far between. We know that there is a very robust database of health effects associated with the type of air pollution that you've alluded to, and and that's the basis for the alerts with respect to the air quality index of what's designated as healthy and very unhealthy. I mean, there's a very robust scientific database that supports that. So whether or not one needs to do that type of work within a military population is debatable, given that robust nature of that of that work. The recommendations of the 2008 committee, they were arguing for improvements in exposure assessment, but that's an incremental process. I mean, that the exposure assessment and the exposure estimation of retrospectively and prospectively is taking time, and one is not really in a position to necessarily firmly estimate exposures in that type of situation. So it has to, and that's probably, that is the motivation for a presumption, where you presume exposure, where you don't have a good mechanism for actually identifying exposure in people. So yes, I think and the bottom line, in answer to your question, the framework that's proposed would incorporate type of exposure as well, rather than some very specific exposures.
Well, that's good to hear. Speaking with, for example, General Miller in Afghanistan, almost all of the folks who have served there for any amount of time have a cough, and we can anticipate, and the general pointed out to us that he thought that a lot of the young folks coming back from that would have respiratory issues much earlier. So it's something that, we certainly need to capture in our reforms and legislation going forward, and with the VA and the VBA. So thank you for your help understanding this. And with that, Madam Chair, I'll yield back.
Thank you, Mr. Allred. I'd now like to recognize Mr. Sablon for 5 minutes.
Yeah, thank you, Madam Chair. Good morning, everyone. I may sound like a broken record, but I am in a district that has very little VA presence. Basically, we have a contracted medical doctor, and then we have the occasional visits from the VBA. Like we're talking here about, respiratory toxic environments from the Gulf War. There are other conditions that I don't know if the VA participation presence here can identify. The GAO report found that VA has to be sort of directed to get its reviewers trained, and that while the VA has allowed its contracted medical examiners to conduct Gulf War exams and train them, not all of them may be trained. And I was wondering if there's anyone who could tell me if the contracted physician here in Marianas has taken the training for the Gulf War unit. Would anyone know?
Yes, sir. This is Ms. Murphy. Those examiners have taken the training.
Here in for the Northern Marianas.
Yes.
All right. Okay. Thank you. Thank you very much. That's good to know. Because look, I'm going to use myself as an example. I served in the reserves. I came in. I was 26. I was overweight, actually, very, very overweight. And I had to change my uniform twice because I kept losing weight due to the training. But since then, I have had 3 surgeries on my spine. And I'm not trying to prove that they are service connected because, you know, I didn't go to war. I went to training. But I tried to get also my GD 214, and all I had on record was a 3-day processing at Fort Jackson for processing to go to basic training. And I know that there are more documents. I served for 6 years, and just the fact that some of those records may also be missing, it's going to be difficult for veterans to prove their service-connected disability, and the presumption, giving them some presumption is going to be difficult if the records are not there. And to just say that in the general population, there are many people with hypertension, for example, because here we have many people with hypertension and diabetes. There may be, you know, those veterans who have this health illness because they were in the war, or we have some Vietnam veterans here also. But I find this GAO report to be very informative, and so Madam Chair, I'm asking permission, the ranking member, if I could take this report and post and publish it in my newsletter and post it on my website where veterans can come and look at it and see how informative it is for them. Would that be appropriate, Madam Chair?
Yes, Mr. Sablan, that would be excellent if you are able to share the report more widely with veterans.
Okay, thank you. And I want to thank Ms. Gerda also for this good work. Mr. Bowles, congratulations, sir, on becoming a ranking member. You have to now sit next to Chairman Takano. God bless you.
Thank you very much.
But it's on Dr. Shukin. It's really nice to see you, sir. I still remember that Valentine's Day breakfast you hosted at your office, and I really was very, you know, my heart dropped when you had to leave VA because you and I started a good conversation, and basically it stopped there. But I've got to continue to persist, and my time is up. So everyone, thank you. If I don't get to see you guys, everyone have a Merry Christmas and a more normal 2021. I yield back.
Well, thank you, Mr. Sablan. I would now like to move into a second round of questions and like to recognize myself for 5 minutes. I'd like to turn back to Ms. Murphy. As we mentioned at the beginning, the purpose of today's hearing is to understand the process that the VA takes to create presumption of service connection. And although you have said that, you know, veterans are able to use direct service connection approach in lieu of a presumption to apply for the benefits, it's clear that a large number of veterans are still being turned away for exposure, toxic exposures, and specifically related to burn pits because they can't prove that burn pit exposure caused a specific illness. And, you know, a second piece of this, and Ms. Carson mentioned in September's hearing that, you know, we still encourage veterans to apply if they've been exposed to burn pits, but, you know, the bottom line fact is that today, 78% of those cases that directly reference burn pits are still being denied. And an additional aspect is that it also seems as though if veterans develop these symptoms after their service or a certain delayed period of time after their service, separation from service, they're being denied. And so, Ms. Murphy, you mentioned that, overall acceptance of these claims is 63%, but we are seeing a much lower acceptance of the claims and benefits being provided to people who do reference burn pits. So I'd love for you to describe that discrepancy. I mean, because, it seems like we have a relatively successful rate at, addressing these claims in the overall population, but for some reason, we're at about 1/3 of the success rate when people specifically mention burn pits. So is there an obstacle in the current process? And then can you comment further on, what do we need to do to take the burden off of the veterans in this situation? And do you think that a presumption is the correct way to go as far as burn pits are concerned?
Certainly, and there's a lot of information. In your opening statement, you said that the sentiment that we're not granting benefits is the opposite of what veterans should feel about the VA. I completely agree with you. I also think that VA can do a better job with explaining in our messaging about what that very narrow population of burn pit exposed veterans and that 22% grant rate means. And we would appreciate your assistance in getting that message out.
I'm sorry to interrupt, but
Yes.
what is the message? If
Yes,
78% are getting denied, and does putting burn pits specifically as a cause actually make it harder for a veteran to get benefits for respiratory problems? It's what it sounds like,
Yeah,
because it's lower than the overall rate.
And I understand what you're saying, and I totally agree with that we need better messaging. If I could start big picture very quickly, overall, Gulf War veterans, over 2.5 million who have filed claims, about 94% are service-connected for something. Within that population, if you were deployed, you've got an average of about 5 service-connected conditions, and your disability rate's at 60%. For those who say burn pit exposure explicitly somewhere in their claim, they're service-connected for about 8.8 conditions, and they're getting an average of 70% service connection. The last couple of points I would make is, of all the Gulf War deployed claimants that we're seeing just specifically for respiratory conditions, that's that 63% are service-connected for a respiratory condition. That 22% grant rate we're talking about is a very narrow 12,000 out of this 2.5 million, very narrow 12,000 who somewhere in their record have the words, based on a word search we've done, of burn pits. And I think that's, a way that we've tried to track that administratively within VA, but it may be doing a disservice to the messaging to the greater population, that we're not waiting for presumptives. While the work continues, we're granting claims in large numbers and at high rates among these populations. I don't know if Ms.
Correct me if I'm wrong. I mean, this is your data that shows this very low number of approval. Yet you're saying that you have other data that shows a much higher success rate for respiratory issues.
Correct.
And you also, in your comments just now, you said Gulf War veterans. To me, that talks about a particular time frame and era. When we talk about burn pits, we're talking about a much larger number of veterans through Southwest Asia, Iraq and Afghanistan specifically at a more recent time frame. Are you also including them in this data, or are you specifically talking about just Gulf War era veterans?
We're talking about the broader population. And Ms. Carson may want to add.
Ms. Carson.
If I may, we don't want the burden to be on the veteran to determine whether or not he was exposed to burn pits or Agent Orange or any type of disability. If a veteran feels that he or she has a service-connected, a health condition that is related to his or her military service, they need to come to us. That's the messaging that we need to put out there first and foremost. It's incumbent upon us to determine how that condition was derived. And I think that challenge sometimes is that oftentimes they may have information where they know they were exposed to burn pits and it's related to that. Other times it's something else that may have caused it. But if they feel that they have a condition, the messaging that we really want to put forward is come to the VA and file your claim for service connection. And I think that sometimes when they hear the statistics, they kind of get disheartened and don't want to come and don't think they should apply.
Well, thank you. And I think that the statistics that you're using, if they're not truly reflective of the success rate of these types of claims, perhaps the VA should examine the data in a way to provide better confidence to the veterans that their claims are being fulfilled. So I'd be interested to understand moving forward some more reflective data if you're saying that that is a very narrow pool of veterans that
Yes,
that applies to. So
And I
would love
would-
to continue that discussion.
Sorry, ma'am, and I would not disagree with that, but I also want to put the point out there that sometimes a person may write burn pit exposure somewhere in the claim, but they're also just claiming a broken ankle condition. So we can find that's not going to be it would never be something that would be presumptively related to the burn pit exposure, but we may or may have to grant or deny that disability that they claimed is related.
Okay, I know I'm going over my time, but your data should reflect reality. And if you're talking about people who wrote burn pit exposure as I'm filling in a blank of things I could have been exposed to during my service, but they had nothing respiratory in their claims, then you should have a process to remove those. I mean, I think that what we care about is people who were exposed to burn pits and have respiratory or other health conditions that could be directly related to burn pits. And so I think that the data should reflect that, and perhaps we're talking about a number, based off your remarks today, that's not truly reflective of people who were exposed to burn pits and have respiratory issues. I mean, I think that broadly talks about the group of veterans who we want to make sure get VA healthcare for that exposure. So I'm sorry, my time has run over, and because of that, I'll also offer 6 minutes to the others because I did take additional time. And so I'll recognize Mr. Boss for a second round of questions.
Thank you, Madam Chair. So, Dr. Hastings, I want to follow up on whenever my questions came to an end a while ago, and I just need a quick answer so we get on, so it's on the record. After hearing everything that the recommendations of Dr. Verdel's, are your plans to have a way to implement those suggestions?
The National Academy report that came out had 4 recommendations, and yes, we are looking at those right now. Those are submitted to the Secretary for review. Recommendation number 1 was establish an expert panel to advise it on issues with regard to constrictive bronchiolitis in veterans. Recommendation number 2 was updated analysis of mortality in the Southwest Asia Theater of Operations, and I will tell you we are doing that now. We have, my epidemiology section is extremely good, and as you know, many of the research articles that have been looked at by National Academy are done by my office. Recommendation number 3, the committee recommended that VA and DoD explicitly integrate research access considerations into their planning. We are absolutely doing that. EILR, which we're very proud of, and in the future we will be able to do closer monitoring, follow people, and veterans won't have to seek information. We will have it, as well as the electronic health record. Recommendation 4 was that VA continue to expand its partnership with DoD on environmental health issues. We meet monthly with DoD to discuss health issues, everything from garrison exposures on up through the latest with Karshikanabad. And absolutely, my office exists to look at how we can better care for veterans.
Thank you for putting that in the record. I got a question here from Ms. Field. In 2016, the GAO issued a report concluding the Department of Defense had not fully assessed the health risk of burn pits. The report recommended that the Secretary of Defense, in coordination with the Secretary of Veterans Affairs, specifically examine the relationship between direct individual burn pit exposure and potential long-term health-related issues. What was the response to this recommendation, and what steps are you aware of that the DoD and the VA have taken since then?
Thank you, Ranking Member Bost. The response to that recommendation that my colleagues made in a 2016 report was a partial concurrence. As you noted, GAO recommended that DoD and VA collaborate to more carefully research the effects of burn pit exposure in terms of health. Since then, DoD and VA have taken some steps. For example, in 2017, they held a joint airborne hazard symposium, and those steps are good. But what we are really hoping to see and would need to see in order to consider our recommendation to have been implemented is a more robust epidemiological study. Specifically, we recommended that DoD and VA conduct a study that meets all of the criteria set out in a 2011 Institute of Medicine report that specifically said that a strong or sound epidemiological study will identify the relevant study population of adequate size, comprehensively assess exposure, carefully evaluate health outcomes, ensure adequate follow-up time, use reasonable methods for controlling, confounding, and minimizing bias, and lastly, perform appropriate statistical analyses. That has not happened yet, and it certainly would be a positive step in the right direction as it relates to this question of whether there should be a presumptive service connection established.
Okay. Ms. Murphy, would any of your team like to, you or your team like to respond to the same way?
I think Dr. Hastings would like to add to that.
Absolutely. Thank you very much, Chair, Ranking Member Bost. We have actually had 5 airborne hazard symposia, and we had our last one virtually in September. We are embarking on research. Part of what you did for us was gave us the Airborne Hazards Open Burn Pit Center of Excellence. Right now, and I submitted it to you in September, the research that is being done there, and we have 42 different research protocols that are there, and we are working on them with our DoD partners as well as academia and my office. We recognize that we need to get answers, and we are looking at the same things that the GAO recognized. We need sufficient size, we need sufficient time because some things may not show up right away, and we need sufficient analytical emphasis to see what the data is telling us. So we absolutely are doing that. And the Airborne Hazard Symposium is a shared meeting between DoD and VA to make sure that our clinicians understand the research that is out there.
Thank you. I'm kind of short on time, but I'm going to try one more question here. Dr. Vidal, can you explain whether the limit of suggestive evidence standard that the NAS used for Agent Orange reports in 1990s carries the same degree of scientific certainty as the modern limited or suggestive standards which NAS applied to on the September 2020 burn pit report?
Yes, thank you. I think the assessment at the in the initial report in 2008, and then comparing our most recent report in 2020 with respect to that issue was that no, there's not been sort of consistent application of limited suggestive from the perspective of the National Academy of Science. There have been, and what I mean by that in particular is that the degree of evidence and the quality of the studies that are included in making that characterization varied over time. And that's one of the problems that was identified as early as 2008, is that there's been this lack of consistency, some of it on the part of the National Academies, some on the part of VA, in terms of actually applying this standard. So I think in answer to your question, that has been that have been goalposts that have been moving. So and that's a problematic issue, because one would like to see consistency here.
Thank you. I'm out of time, so I'll submit for the record my other questions. Go back.
Thank you, Mr. Bost. I'd now like to recognize Chairman Takano for an additional 6 minutes for a second round of questions.
Thank you, Chair Luria. I appreciate that. Let me see if I can get right into this. I want to return back to this rational basis standard and what fits. Ms. Murphy, why hasn't the Secretary made a decision on Agent Orange presumptive diseases, on hypertension or other diseases, other additional diseases such as stroke yet.
I asked Dr. Hastings to comment on that. She's been on the science and medicine side over those deliberations.
Chair Takano, absolutely. The reports were done by the National Academy. They were submitted to the Secretary. In consultation with our other partners, it was felt that more scientific evidence was necessary, and so we are awaiting the two studies that we have spoken of before in regards to the Agent Orange presumptions that have been proposed most recently.
Well, isn't there, and forgive me if I don't know this exactly, but isn't the finding of the NAS that there's more than limited or suggested evidence of hypertension being related to Agent Orange?
We absolutely take what the National Academy says very seriously, and as I said, that the report that pushed the National Academy over into the sufficient evidence was a study that was done in my office. However, when you look at the entire United States population, it was felt that we needed more information to, since 80% of the U.S. population has hypertension, that we wanted to see what we had in two specific Vietnam studies that were not included because not completed at the time for National Academy to look at.
Well, so that's your reason for why the same evidence was sufficient in one case, but not sufficient this time. Is that we're talking about a large number of Americans, a large number of Americans already have hypertension, and I see that you don't want, that you don't want to separate out. You need to separate what is actually sort of related to Agent Orange exposure. What additional evidence is VA waiting for to make a determination on additional diseases? And so you just told me that you're waiting on a couple of different studies related to hypertension. What about some of the other diseases?
The diseases that were considered at the same time by the National Academy or added to the sufficient evidence or limited or suggestive were, of course, bladder cancer, an expansion of the definition for Parkinson's, and hypothyroidism, along with the hypertension. All three were considered, all three were discussed with our federal partners and felt to have a need for more science, more research prior to making the final decision.
Well, thank you. Mr. Vidal, in your testimony, you described the need to change the wartime exposure classification of evidence for Agent Orange from association to causation, and need to quantify the effect of exposure during military service, particularly for diseases with other risk factors and causes. Do DoD and VA currently have systems in place that could help you quantify these risk factors during military service?
I guess in answer to that very specific question, I think they do to some extent. They have a health record that's been alluded to, and that health record does gather information on other risk factors. But I don't think it's comprehensive that they would have information on every veteran that we needed that information on. There have been some, the discussion at this point, has been perhaps a little bit muddy. I mean, the first sort of issue is, first of all, to assess the relationship, that is the evidence in relationship to an exposure and a health outcome. And then we've heard the second sort of issue, which is also an important issue, is how much of a role does service exposure actually play in a health condition? And it is also an important consideration. And the example that's been provided is hypertension, where one would be clear that the vast majority of those who would be, if there were a presumption for hypertension, would receive a presumption and receive service connection for something that had nothing to do with their service exposure. However, if one feels so strongly that you want to be able to make sure you capture every person who might have had a connection between service exposure and hypertension, then that may be something that one wants to do, even though you're actually giving a presumption or service connection to a large population of veterans in which that was not the case. That is, in which there was no service exposure that resulted in hypertension. The same can be said, for example, for type 2 diabetes and Agent Orange, which was problematic for the same reason.
I get that, Dr. Vidal. So your answer basically is yes, that we do have systems in place, but they're not comprehensive. They're not enough, probably.
Well, I'm not sure I'm the one to be addressing that question. It's probably VA in terms of what they have in their records about other risk factors to be able to actually give you an estimate of what the service attributable risk is for any given condition.
Thank you. I want to be courteous. I don't want to. I've gone over my generous 6 minutes, so I better yield back. Thank you.
Well, thank you, Chairman Takano. I'd like to call on Mr. Sablan, also for 6 minutes for additional questions.
Yeah, thank you very much, Madam Chair. Look, any member needs question, Madam Chair, Chairman Takano, you need any additional time? I could share. Otherwise, I'm going to pass. So you want to use my time? Anyone?
Well, thank you, Mr. Sablan. Mr. Takano, would you like
All right.
to take advantage of any of Mr. Sablan's time?
Sure, I appreciate that, Mr. Sablan. I appreciate it, Madam Chair. Hold on, did I mute again? I'm sorry, I got to.
No, you're okay.
I'm okay. All right, thank you. Thank you, Mr. Sablan. Well, so my question, let's go back, Mr. Vidal, back to these systems. Do DoD and VA currently have systems in place that could help you quantify these risk factors during military service?
Right. So that was sort of incorporated in some of the recommendations that were made earlier. But I guess I'm not the person to answer that in terms of the actual richness of the data that are collected. It would seem unlikely that there's a comprehensive effort now, and certainly from DoD, to collect data on all health risk factors during service. So that would be difficult. I think after the fact, when the physicians at the VA and such take a history, I mean that's undoubtedly part of their overall process is to assess the existence of other risk factors for the condition. So whether that's in the record or not, I'm sure it's utilized at some point.
All right. Well, I'm going to try to get down to who I do need to ask this question of. But let me follow up. Does evidence for burn pits and airborne toxic hazard exposures need to be reclassified to causation, or has the approach changed for these type of exposures?
Is that for me again?
Yes, please.
Yeah.
Yes.
So the latest National Academies report used the organization of evidence that has been used often, which has been classifying it as limited suggestive. Our earlier recommendation is that approach be abandoned, which is going to take some doing. But the rationale for doing that is that limited and suggestive of an association puts an incredible amount of weight on observational or epidemiologic findings. The whole motivation for attempting to characterize the evidence as being related to causation, more likely than not, is intended to incorporate the entire spectrum of health findings, including toxicologic findings, including mechanistic findings that have been alluded to, in order to make a more global assessment of the association. So I think the committee at that point had felt that just assessing association was not adequate. Now, in the meantime, as I mentioned before, there is a correspondence between the two, but it's not complete.
All right, well, thank you. Thank you. Ms. Field, the VA's list of the diseases associated with exposure to Agent Orange or other herbicides during military service for which veterans and their survivors may be eligible to receive disability compensation benefits has generally incorporated the findings of the biannual reviews performed by the National Academy of Sciences. GAO reported at that time of the Academy's 2014 report, which was issued in 2016, the VA's list included 5 diseases identified as having sufficient evidence of association and 9 identified as having limited or suggestive evidence of association. The Academy's 2014 biennial report also listed 4 additional diseases: cancer of the urinary bladder, hypertension, stroke, and hyperthyroidism that is categorized as having limited or suggestive evidence of association that were not included in the VA's list of diseases. In addition, on the same day that GAO issued its report on November 2018, the Academy issued an update in its biennial report, changing the assessment of hypertension from limited or suggestive association to sufficient association, and identifying a new health outcome, monoclonal gammopathy of undetermined significance, for which there is sufficient evidence of association. Please discuss any relevant changes that have been made over time to the 14 diseases that are currently on the VA's list.
Thank you, Chairman Takano. So we've talked a lot about this today, that as more studies are conducted, as more evidence is collected, the way in which the Academy has characterized or categorized diseases may change. And we have seen diseases drop off, such as spina bifida, for example. That said, when we look at the 14 diseases in the Academy's reports from 1994 through to the most recent one, for the most part, what we observe is that the level of evidence related to an association between exposure and that disease has typically gone up. For example, chronic B-cell leukemia was identified in the 1994 report as having inadequate or insufficient evidence of a connection, but in 2002 that moved up to sufficient evidence. So it is, based on what we have seen, more common for diseases to be upgraded.
All right, well, thank you. Thank you. I yield back.
Well, thank you, Chairman Takano. And that concludes our second round of questions for this panel. And also, we are ready to move on to our second panel. And I would like to introduce our witnesses for that panel. First, we have former VA Secretary Dr. David Shulkin joining us today. And we also have Ms. Anita Ritchie, who is the Senior National Service Officer for Benefits and Appeals with the Wounded Warrior Project. And I would also like to note that multiple other veteran service organizations have submitted statements for the record in support of this hearing as well. Dr. Shulkin, welcome, and we'd like to start with you. I'd like to recognize you for 5 minutes, and thank you for joining us.
Thank you, Chairman Luria, Ranking Member Boss, members of the subcommittee, Chairman Takano. I really appreciate the opportunity to provide my perspective on this important topic. Like you and all our fellow citizens, I share the belief that we all have a responsibility to support those who have served and sacrificed for the rest of us. And I very much appreciate your efforts to improve the system for our veterans. As Secretary of the VA in the Trump administration, and as Undersecretary of the Veterans Health Administration in the Obama administration, I saw firsthand how the Department of Veteran Affairs is an essential and extraordinary resource for our country's veterans. The thousands of men and women who work in the department are by and large passionate about their service, like what we've seen here today, and they work very hard to deliver the benefits our veterans have earned. However, they work in a system that's often complex and bureaucratic to the point that it can be difficult to ensure that veterans get the benefits that they need and deserve. When I was secretary, I heard from numerous veterans and their families about the difficulties they face in navigating the VA. These difficulties translate into delays, and these delays translate into veterans going without the help that they need, sometimes for years. The current benefit system too often perpetuates an adversarial relationship between the veteran and the VA. Many veterans who struggle to obtain initial benefit decisions become locked into a complicated process requiring them to prove their level of disability. Few incentives exist for veterans to improve their health status and decrease their disability rating. As Secretary, I had announced my intent to reform our disability compensation system, but unfortunately, I didn't have time to complete this before leaving the VA. In my view, the way our benefit system operates is backwards. It requires a veteran to prove that their disability or injury was service-related and that the association between an exposure and an adverse health consequence has been scientifically validated. This process leaves an individual veteran to fight a system that is too often too much for her to take on. Many veterans just give up or never bother in the first place. The system I see for our veterans is a system that would be proactive rather than reactive. It would rely upon the available documentation and science when that's available, but when the data is not available, but appears to be plausible, VA would give the veteran immediate access to service and benefits. In other words, the veteran would be given the benefit of the doubt. As Secretary, I was working on a system that would grant benefits to those that were injured or disabled without having to go through the complex array of examinations, assessments, hearings, and appeals. This concept, rooted in the science of behavioral economics, would get veterans benefits sooner, streamline the administrative processes, and ultimately save the taxpayer money. In our current system, we're too often seeing different standards being applied for the determination of benefit decisions. As Secretary, I reviewed the new presumptive conditions for veterans that had been exposed to Agent Orange. After studying the data in 2017, I recommended the new presumptive should be granted for bladder cancer, hyperthyroidism, and Parkinsonism-like syndromes. However, despite my recommendations as Secretary, the Office of Management and Budget stated I was not using the appropriate standards for this determination, and the effort was stalled. I'm now very pleased to hear that these presumptives are included in the next NDAA, but once again, the process has resulted in our veterans waiting too long for help. As Secretary, I had determined that when clear scientific associations were not possible to determine, the correct standard was more likely than not in making presumptive determinations. Others, however, felt that the standard should be a much more statistically significant scientific association. For example, the VA has been unwilling to move forward on presumptives for veterans with burn pit exposures, saying that there's not enough data to make the determination. The NAS reports say that there's not good enough data on which to make a determination. So again, veterans are caught in the middle and are just left waiting. They wait, even though there's a low likelihood of better data becoming available. It's my opinion that Congress should legislatively improve this process. It should make a clear standard for presumptions so there's no longer inconsistency in the interpretation for decision-making. Second, Congress should put timeframes around this decision-making so years do not pass without a determination. Finally, while these legislative efforts are underway, veterans should not have to wait. They should be granted access to healthcare services and benefits where the condition is more likely than not related to the veteran service. Reforming veterans benefits is going to be challenging, but it's necessary. The status quo does not work for too many, and the commitment Americans have to our veterans is too important to forego needed reforms. Madam Chairman, thank you today for the privilege of testifying before the subcommittee. This concludes my remarks, and I'm willing to answer any questions the subcommittee or Chairman Takano may have. Thank you.
Well, thank you, Dr. Shulkin. I'd now like to recognize Ms. Ritchie for 5 minutes.
Thank you very much. Chairwoman Luria, Ranking Member Bost, Chairman Takano, and distinguished members of the subcommittee. On behalf of Wounded Warrior Project, I thank you for the opportunity to submit today's testimony, which will address the barriers to VA health and benefits access for military toxic exposed veterans and what we might do to remove such barriers. In our written testimony, we request that this subcommittee address 7 key areas of improvements we recommend be made to the VA health and benefit systems, including access to health care, complications with proving the long-term health effects of military toxic exposure, and the role these complications play in the VA benefits claims process. Today, I would like to share the all too common story of one of our warriors, whom we will call Jeff. Sadly, his story is not unique and will highlight many of the issues outlined in our written testimony. Gathering evidence for a VA claim is difficult, even for veterans who have access to health care, without the aid of legal presumptions or the assistance of tools to confirm exposure in service. Such is the case for Jeff. Jeff served honorably on active duty for more than 20 years in the U.S. Army and the Army National Guard. In 2004, Jeff deployed to Fallujah, Iraq. As a sapper disarming IEDs, Jeff's job involved countless hazards. He told me about the nights he spent finding it difficult to breathe while overseas, and how he always seemed to be covered with dust that would never stop collecting on his person. But as anyone who has served in a combat zone will tell you, proving what hazardous materials were contained in that IED or what the dust was made of is only possible if the DoD is monitoring the types of chemicals in the air and water. Without DoD research, verifying exposure via some other method is simply impossible. When Jeff left the service 10 years ago, he did not know that a rare and aggressive type of leukemia was taking root inside his body. A leukemia that overwhelmingly occurs in young children. A leukemia with a very high mortality rate. When Jeff told me of his diagnosis, I was shocked. When I first met him in 2016, he was a physically fit 49-year-old man who liked to run, did not smoke or drink, and had a full-time desk job since leaving service. 2 years later, his cancer led to the annihilation of his immune system. But Jeff is a born fighter. He worked diligently to produce every piece of evidence I identified as critical to his service connection claim. He sought evidence from his private medical providers, from his branch of service, and even from environmental exposure experts in an attempt to prove that his likely exposure to ionizing radiation, depleted uranium, and airborne toxicants have undeniably played a role in the development of his illness. His recent urinalysis showed levels of heavy metals that exceeded 3 times the upper expected limit of the reference population. Yet despite our best efforts, his claim has not been successful. We cannot irrefutably prove that he had exposure to toxicants and cannot prove that toxicants caused his cancer due to lack of information and lack of conclusive scientific research. In an attempt to secure additional evidence assistance, we have filed an appeal to the Board of Veterans' Appeals. This is a process that takes time that Jeff really does not have. Another obstacle to his claim has been obtaining a medical opinion supporting causality between his toxic exposure and his leukemia. So far, Jeff has had 4 VA compensation and pensioners examiners weigh in on this issue. While one provider asserted that a relationship exists, the other 3 disagreed. They use the same reason we commonly see in unfavorable VA medical opinions. A strong association is not proof of causation. The VA did not concede toxic exposure, thus VA examiners will not speculate on the connection of leukemia to service. Jeff is not alone. He is legion. This is the struggle of thousands of military toxic exposed veterans. Theodore Roosevelt said, "I believe that the more you know about the past, the better you are prepared for the future." As discussed in our written testimony, we have learned from previous generations of veterans how to identify the critical improvements that must be undertaken if we are to prevent history from repeating itself. Without providing access to care and tools to help verify exposures or establishing presumptions based on the use of already existing federally funded research, we may already know what is to come. Chairwoman Luria, Ranking Member Bost, members of the subcommittee, this concludes my statement. Once again, I would like to thank you for the opportunity to provide Wounded Warrior Project's views on this important issue, and I look forward to your questions.
Well, thank you, Ms. Ritchie, for your testimony and for sharing the story of Jeff, and also for the work that you do at the Wounded Warrior Project to represent and assist veterans such as Jeff. I will recognize myself now for 5 minutes for questions, and I'd like to go back to Dr. Shulkin's statement and just pull out a few words that you mentioned, Dr. Shulkin. You mentioned this adversarial relationship between veterans and the VA, and I think that Ms. Ritchie's story about a particular veteran who she's worked with who has very dire and urgent health concerns and needs, and wants that help from the VA and has this huge burden of providing a large amount of evidence to link his condition and his current health concerns to his service, is a perfect example of this adversarial relationship where the burden is placed on the veteran that you're referencing. And, as members of Congress and looking towards the work that we can do in the next Congress, the 117th, can you provide us with some ideas from your work and the things that you would suggest we could do to make this process easier for veterans, to take this burden off of them, and to help make sure that they get the health care that they need in a timely manner?
Yeah. First of all, Chairman Lurie, thank you for your question, because it shows that you really do have an appreciation for what thousands of veterans and their families are going through, the story of Jeff just over and over again. And, we have developed an entire bureaucracy at the Department of Veteran Affairs to deal with these issues. And the end result are hundreds of thousands of appeals that we've been dealing with for decades. And frankly, our veterans have been waiting for decades. When I was secretary, I dealt with World War II veterans who were exposed to mustard gas that had never been given the benefits that they earned. And then, of course, we all know the story of the Vietnam veterans, and then come the Korean veterans and every generation, we just repeat the same thing. So basically, I believe the system that we need is we need to do a better job of collecting the data right from the start, like several members of the subcommittee have talked about. Where there is data, we need to make quick decisions, but where there's not data, but there is essentially more likely than not a plausible explanation, we should be granting the benefits at that time, and certainly not making people wait without benefits or without health care while we go out and collect data. Too often, the Department of Veteran Affairs has used waiting for studies and issuing additional studies for essentially decades and not making decisions, and it's just not appropriate. We can act like the private sector acts in the disability world and grant decisions early on. And frankly, I think it's going to save taxpayers money in the long run than this constant decades of appeals and reappeals.
Well, thank you, Dr. Shulkin. And, just thinking about that suggestion that you've made about prompt granting of the approval and the access to the healthcare, I guess one question I have, and I don't know if you can comment on, if you think it's realistic that, we would grant a veteran that care and then evaluate it as time went on, do you find it problematic that may at some point necessitate reducing or removing the care based off of further evidence, and how would we deal with situations like that?
Well, I do believe that it is time to be trying something different. Continuing the current system that we have, frankly, isn't something that I think is in the benefit of veterans or taxpayers. So I think we should be trying, just like in the healthcare system, different experiments or different pilots on disability compensation. I do believe lump sum payments up front, where you can make a determination. There has to be some type of economic exchange for a upfront determination where veterans get the help. I believe that is certainly something that should be tried. And that's what I'm talking about the science of behavioral economics. I do believe that you can grant people immediate access to help. And if there is data that comes down the road, I believe that it is appropriate to be able to reevaluate those decisions. But that has to be done with a transparency up front so the veteran understands that may be a possibility. So, but our current system of just making the veteran wait without help, I think, is the worst alternative of all of them.
Well, thank you, and thank you for your work and your thought that you've put into this topic, and we certainly appreciate you sharing that with us in the format of this hearing. And I know that as we move into the next Congress, I think that we're all united in saying that we want to take that burden off of the veteran, and we will definitely take into consideration this and other concepts that could help relieve that burden from our veterans who have served. My time has expired, and I will now recognize Mr. Bost for 5 minutes.
Thank you. And Dr. Shulkin, if you could, I want to keep going down that same road. If you could explain why you believe Congress should establish a clear evidentiary standard for presumptive conditions.
Well, I think, Ranking Member Bost, when you go back and you take a look at the history here, this has been a problem. The different definitions being used by how Congress interprets it, how veterans groups interpret it, how the Secretary of the VA interprets it, and in my experience, how the Office of Management and Budget interprets it. And the end result is, if there's not an agreement upon a clear standard, the end result is we usually go out and do further study, and that results in veterans just simply not getting the help that they need and being delayed in the help. The fact that we have so many veterans currently with burn pit exposure, and as Chairman Lurie said, a 78% denial rate, simply suggests that we could be doing this a lot better. And I think a lot of it has to do with the clarity of the definition. When I went back and studied congressional intent on this, that goes back to 1921 when Congress first established presumptives, I believe the correct standard is more likely than not. And that's the way I based my decisions as Secretary. I believe that that was the correct standard. The Office of Management and Budget did not agree with that. And so we were locked in a debate over definition. I think Congress could help clarify what that intent is. And once that's clarified, I think then there wouldn't be as much argument over what the right standard is.
Yeah, and Dr. Shulkin, your testimony provided multiple recommendations for the VA and can improve the claims process. One of my priorities as the next full committee ranking member is to look for ways to create effective efficiencies and increase accuracy in the disability compensation claim system. Would you support legislation that, as we move forward, to establish a working group to scrutinize the claims process, similar to how Congress and the VA partnered with overhauling the appeal system?
Absolutely, Chairman Bost. I can't tell you how happy I am, of this sort of bipartisan commitment to do this. This is an outdated system, and it's not the fault of terrific individuals who work in the VA, like the people who are testifying on the first panel today and many others. But look, we have a C&P exam that, frankly, has its roots in 1940s medicine. You can't even find the types of devices today that are being used. We have a disability compensation system that is basing its decisions on very old ways and regulations of doing things. Today, we should be using large data analytics, predictive analytics, to be able to provide individualized determinations of compensation that frankly could be done in a very short period of time, very accurately, using scientifically validated ways of doing this. And so your attention to updating this system and doing exactly what you said will help thousands of our veterans and their families and really honor the commitment that we made to those veterans when they raised their hands to serve.
Yeah, I've got a personal story that I think I've told to you and others, and that is the fact that I lost all my high-frequency hearing in the Marine Corps, and at 22 years old, ran home instead of sitting and going, because I just wanted to get out of the service, and then did not know the frustration until later life, where I applied 3 times and was denied 3 times for that. And I don't want those benefits now, but I do know what people go through when they are denied, and because of that, it kind of puts a drive in your heart to make sure that the veterans are given those benefits when they deserve them, and to try to jump through a bureaucratic nightmare that continues to go on appeal after appeal after appeal is one of the reasons why I'll be working very, very hard. And I look forward to working with you and others on this as we move forward over these next few years. So, and thank you, and I will yield back.
Thank you, Mr. Bost. I'd like to recognize Mr. Sablan for 5 minutes.
Yeah, Madam Chair, unless anyone needs my time, I pass.
Thank you, Mr. Sablan. And Mr. Bilirakis, I'd like to recognize you for 5 minutes.
know if you can hear me. Can you?
Yes, we can.
Okay, thank you. Ms. Ritchie, both the Senate Bill 4393 and HR 8506 would legislate commission that would make recommendations to VA about NAS studies, which may inform a presumption for toxic exposures. VA would then be required to make a determination whether to establish a presumption following the release of such NAS report. Why does WWP support the presumptive decision-making framework outlined in these bills?
Yes, can you hear me? Sorry.
Yes. Yeah.
Thank you for your question. So one of the main reasons why we support presumptions is because VA disability claims are based on the establishment of evidence. Evidence is the bedrock of a VA disability claim. If you can lessen those burdens for veterans so that they are able to, especially in the case of seriously ill, and especially in the context of military toxic exposure, provide them with a path to claims granting that they probably wouldn't have otherwise, because there's just not enough known scientifically. That's kind of critical right now. The one thing that I did want to point out, the presumption, or not just the presumption, there's many legal presumptions that already exist in VA law that don't always get applied in these cases. For example, there's a combat presumption. So if you served in a combat zone and you claim that something happened to you in that combat zone, Congress and the VA said, we're going to lessen that evidentiary burden of proof, because they know that it's really hard when you're downrange to get access to care, for example. So in those situations, we want to see the use of presumptions more frequently, because they allow people in those circumstances to prove something that would otherwise be unprovable, frankly. So does that answer your question?
Well, no, and it does answer my question. And I agree with you. You know, sometimes it's hard to prove. Again, my goal is to get the veterans who have been exposed to these toxic wastes health care as soon as possible. That's our first goal, and then of course the presumption or the benefits come after that. But the health benefits are what's important right now. Time is of the essence. Dr. Shulkin, it was great working with you, by the way, when you were secretary a couple of years ago, and we got a lot done. So welcome back to the committee.
Thank you.
Thank you again for being here to testify. I know you have touched on this already, but if you can elaborate in your testimony, you specifically mentioned the burn pit issue, that veterans are caught in the middle and waiting because the VA doesn't want to move since there's no clarity in the process. Both of my bills regarding the burn pit exposure claims of this Congress include the TEAM Act, which I mentioned earlier, and that's the companion bill to Senator Tullis's bill. It would mandate a specific timeline for decision making and mandate that the VA provide healthcare services to these veterans even prior to the benefits presumption decision being made. Can you tell me why both of these legislative fixes are important and necessary compared to the current process? I know you're probably repeating yourself, but it's definitely hearing again.
No, well, first of all, thank you for that legislation. I know you and Dr. Ruiz have done a great job in the House in trying to bring important legislation forward. Look, we had 3.5 million veterans who have been exposed to burn pits. Those that have come forward and asked for help deserve our help, and we just simply can't allow them to wait. That's why I think your legislation is important, because it establishes those timeframes. And I fear that with an NAS report that says that there just simply isn't data out there in which to make good scientific associations, I believe our veterans are being given a false hope of waiting for data that's going to show a scientific association. I have reviewed peer-reviewed studies that, in my opinion, suggest that in certain conditions, there is clear enough data to be able to suggest that there are adverse health consequences with these toxic exposures. And, you know, Anita's talked about Jeff as just one of those people, but frankly, we're not honoring our responsibility by not addressing people like Jeff and his family that need our help. And so I think your legislation is required. I think it's unfortunate because I think today the VA has already the authority to be able to act on behalf of our veterans, and they're not acting on that. If you look at the VA website today, it says under burn pits that there is no data to suggest adverse health consequences with burn pit exposure. That simply is wrong. I've called on that to be removed. And because the VA is not acting swiftly enough, your legislation is very critical for our country's veterans, and I strongly support it. Thank you.
Thank you, Dr. Shulkin. I appreciate it. And again, it was an honor to serve with you over the years.
Thank you.
On behalf of our heroes. Thank you, sir. Thanks for your service.
Thank you, Mr. Bilirakis. I'd like to move into a second round of questions, and I'd like to address this question to Ms. Ritchie. I know that the Wounded Warrior Project has been working with a large cohort of veterans advocacy groups, the Team Coalition, to come up with ideas for studying the current and future presumptive conditions. And I commend the work of Wounded Warrior Project with these other VSOs. And, you know, I wanted to go back to a part of your statement where you said that the VA refuses to use research and scientific evidence which already exists in certain cases. Can you elaborate on that and what scientific evidence you're referring to that perhaps the VA could also consider in these determinations?
I'd be happy to. Thank you for your question, Chairman Luria. I unfortunately always speak in anecdotes, but that is because of the job that I do. So forgive me another one, but I have a case of a veteran who served in, was deployed on active duty in the National Guard to the World Trade Center. And the World Trade Center Health Program, which is a congressionally established program that has a place in both the CFR and the United States Code, has a list of presumptive conditions related to first responders who were in those areas and the health conditions that developed. And I had, in my veteran's case, he was on active federal orders. He served in that area. He is a part of the World Trade Center Health Program, and he developed a type of cancer that is on the list of presumptions in another area of law. And unfortunately, we had to appeal his case because VA did not want to recognize that there is a legal presumption already in place for a set of health issues in one area of federal law that they won't apply in this other area of federal law. So that's just an example. But really, we often have issues with even VA's own research body, the War-Related Illness and Injury Study Center, that does provides clinical services to veterans, just getting them to recognize that those medical opinions that are coming from the War-Related Illness and Injury Study Center is good, solid medical evidence, well-rationed medical evidence that can be used to grant a claim. Often we don't see them doing that. We unfortunately see them taking a look at those opinions, not knowing what they're about, because risk isn't mentioned anywhere in the M21, and VA claims processors are still requesting exams when they've got research from people who do that for a living, who are part of the VA. So we kind of hope to see those types of things changed and those types of tools utilized more regularly and in a more standardized way. Thank you.
Well, thank you for that insight, and I've made notes here because these are of particular interest to me, and we'll continue to follow up, hopefully with the VA to understand if there is a process by which they can use other presumptions that are already existing in U.S. code, or it would seem obvious to me that from the risk data, which is being collected specifically for the purpose of identifying these types of illnesses in war veterans, that would be allowed to be used in someone's determination. So I look forward to continuing that conversation. I will now recognize Mr. Bost again for 5 minutes.
Thank you. Dr. Shulkin, one more. In your testimony, you say that a few incentives exist in the current system for veterans to improve their health status and decrease their disability rating. How are you recommending that we change? How would you recommend changes to the claims process, better allowing veterans to improve their health while empowering them to continue and contribute to the workforce?
I think, Ranking Member Bost, we need to try several different new policies to be able to help with the goal of promoting independence and health and wellness among our veterans. That should be the objective and goal of our disability system, which is to get people back to where they can be as productive and as healthful as possible. And the way that you can do that is through one thing I mentioned, lump sum payments, where essentially, despite a person improving and regaining employment, that they would not lose their disability benefits. Now, they would give something on the front end for that. In other words, they would take less of a disability payment to get that lump sum, but then they would not have a disincentive to being able to go back and seek employment. Secondly, there can be direct incentives for involvement in vocational training and involvement in trying to get back to an employed situation or some other type of situation that promotes independence. I think that what you don't want is a system where everyone is being continually reevaluated and re-rated, because that's an expensive process that can be adversarial, and it actually works against what we should be trying to do, which is to get people back into a healthy and independent state.
Thank you, and look forward to taking all your information and working with it over the next couple of years and see what we can do in that way. Ms. Ritchie, please, can you explain why the WWP's testimony, which supported the NAS recommendation that the VA conduct a study on the efforts of all potential in-theater exposures rather than focusing solely on burn pits?
Yes, thank you, Congressman Bost. I believe, the main reason why we want to open the door to more than just burn pits and not just focus on burn pits is because there are a lot of veterans out there, even though I personally serve the post 9/11 community, who've had exposure to all kinds of things. People who served in Bosnia, people who served in Somalia, in different conflicts. So we want to make sure that based on the work of the Vietnam veteran area community, that we are making sure that when we talk about toxic presumptions or toxic exposure, that it's more uniform for everyone. So that's it.
Well, first off, I want to thank the chairwoman for allowing us a second round, and with that, I'll yield back.
Well, thank you, Mr. Bost, and I wanted to say that I'm grateful that we had this opportunity to revisit this very complicated but very important subject for so many of our veterans and their families, and that we will definitely be working together in a bipartisan way to continue to address this going into the next Congress. For the many organizations who submitted statements to today's hearing, we thank you for providing that information, and it does help us understand the scope of the problem and also your suggestions for potential solutions. So thank you again for submitting statements in support of this hearing. To me, it seems there's an agreement amongst most in the community that we need to change the way that we approach compensation for veterans with toxic exposures. And unlike other injuries a service member might suffer, toxic exposure is less obvious and can sometimes happen slowly and quietly, and it can manifest itself at some period of time much later than the member's service. And truly a veteran might have no proof that they can provide as to why they're sick, or why they can't run a mile without stopping and being short of breath, or why they suddenly get migraines, or why they have these other unexplained symptoms that it is difficult to draw the connection back to a toxic exposure that they had during their service, yet that proof is just too difficult. And right now we're leaving that burden of proof on the veteran. So I think that's why we have to reconsider this approach to presumptions, and I think that we received some valuable information in today's discussion, and we'll continue work on this topic. I also think that clear standards for adding new diseases is critical, and I appreciate all the input from our witnesses today for helping us understand how we can approach that both legislatively and through rulemaking within the VA. And I also look forward to working on this as we move into the next Congress. So thank you again. I know that many of you have appeared multiple times before our subcommittee, and I look forward to continuing to work with you on these topics. And Mr. Boss, I would also like to recognize you for any closing remarks.
Thank you, Chair Lurie. It's been an honor and a privilege serving as the DAMA ranking member in this Congress. I also appreciated the opportunity to get to know and work with Chair Lurie. We've enacted some wonderful pieces of legislation, including some notable laws which ensure that the value of the veterans' benefits kept pace with inflation. We provide long overdue benefits to the Blue Water Navy veterans, which we've worked on so hard and finally got that done. We also allowed the display of the battlefield cross in our nation's cemeteries. I look forward to continuing our work next Congress to improve how the department assesses veterans in my new role as a full committee ranking member. And I can't say that I've ever had just such a great honor of serving on this committee and doing the good work that we're trying to do for those men and women who have served this country. And it's a great honor. And with that, I yield back.
Well, thank you, Mr. Boss, and thank you again. It's been a pleasure for me as well to work with you on this subcommittee. And like I said earlier, look forward to working with you as we move forward. And you're the ranking member on the full Veterans Affairs Committee. This now concludes our hearing, and I'd like to say that all members will have 5 legislative days to revise and extend their remarks and include extraneous materials. Without objection, the subcommittee stands adjourned.